Thank you again for the invitation. And it is my privilege to talk to you briefly about hypertrophic cardiomyopathy, where we have come from, where we are now, and where we think we are going, essentially. So before we start, let us understand a little bit of math. This is India. We have to talk about math, arithmetic, right? So HCM, about 1 in 500 prevalence, and that is across the world. No matter what population you look at, 1 in 500 is the incidence, is the prevalence. In United States, if you do that math, there's between 700,000 to 1 million patients with HCM. As of right now, we know of about 100 to 150,000 patients. That means a significant proportion are undiagnosed, underdiagnosed, or misdiagnosed. Extrapolate that into a country like India with 1.4 billion people, and the numbers are staggering. So at the very least, we need to do a much better job of phenotyping, identifying patients before we can think about treating them. So step one, at baseline, I'm an imager. I may be doing clinical trials and other things, but at baseline, I'm an imager. And one thing I will tell you, the most important thing in hypertrophic cardiomyopathy is to establish a diagnosis, ascertain the right phenotype. Where are the symptoms coming from? Is it dynamic outflow tract obstruction? If that is the case, what is causing it? Is it the septal hypertrophy, or is there something else going on? Patients may be symptomatic without outflow tract obstruction due to diastolic dysfunction or apical hypertrophy, what have you. So these four patients here are all HCM patients. One of them has basal septal hypertrophy. The top right has apical hypertrophy. Bottom has no hypertrophy, but gradient. And the bottom right has concentric hypertrophy. Only one of them is gene positive, the one that does not look like HCM on the bottom left, okay? So there's a lot to be learned about this. Echo, while remains the mainstay, CMR does offer complementary value. We are moving towards a brave new world of machine learning and artificial intelligence in everything we do, and including imaging. So the study on the left, we did with my colleagues in London, where we showed that human touch to measuring wall thickness and ejection fraction was not superior to machine after adequate training. The other thing we are learning is we've been taught in medical school 15 millimeters or more is HCM. 13 millimeters with a family history is HCM. Where did that number come from? It's just random number picked by some experts, okay? What we are learning is there's a tremendous impact of age, gender, as well as body surface area in these patients that could account for almost 35% of variation in maximal wall thickness. So we have to fundamentally start thinking in a slightly different way, not just absolute cutoffs. If there is one slide that you need to take home today, it is this slide. In HCM, if looked for carefully, about 70% patients in referral centers have dynamic outflow tract obstruction. If you do not look, you're not going to find, and if you don't find, you cannot treat them adequately. 25% at rest, 70% with provocation. And at Cleveland Clinic, we use everything possible: resting, Valsalva, amyl nitrite, stress echocardiography to bring out the outflow tract gradient. In 2025, designating somebody as non-obstructive without going through the full distance is not appropriate. In fact, this patient I'm showing has no hypertrophy. This person is gene positive. Throughout his life was told he was anxious every time he complained of symptoms. Till we put him on a treadmill, he develops all the symptoms with severe outflow tract obstruction. We fixed his psychiatric problems with cardiac surgery. You know, sometimes you gotta do things. So that's important to realize. So another important thing is resting gradient assessment is no longer enough. You have to provoke. And one thing we are finding out, even in USA and the rest of the countries, UK, et cetera, is people just don't do a good job of a Valsalva maneuver or provocation. Yesterday I heard that in one of the hospitals in North, they do chole bhature and then do postprandial imaging instead of doing a good Valsalva maneuver. I would not recommend that. We got to do the right things, right? If you look at it carefully, it provides incremental diagnostic yield. To me, stress echo provides the biggest diagnostic yield. But there's a lot of techniques that are being developed. This is something that is gaining traction. Doing a Valsalva maneuver where the patient blows into a blood pressure cuff, maintains a blood pressure of around 40 millimeters of mercury. If different people do it, that brings homogeneity, and then you measure the echo images, that gives you appropriate answers, which are consistent across different patients. Another important thing to recognize is the Doppler signals. Systolic anterior motion of the mitral valve is very characteristic of hypertrophic obstructive cardiomyopathy, and that occurs during late systole. So the Doppler signal looks like the bottom left, a dagger-shaped, right? If you see something that is not dagger-shaped, if it is, you have to recognize a continuous, a fixed obstruction type pattern. If your patient has a velocity of 6 meters per second, that is generally not outflow tract obstruction or due to HCM. That is likely mitral regurgitation. So these are some of the things we have to, imaging helps you get to the right diagnosis. As I alluded to, we utilize stress echocardiography very liberally, and it is safe in right hands in the right lab. This is a study which we published in 426 asymptomatic patients. Everybody comes to the clinic and say, we have no symptoms. Prove it to me. Only 1 in 5 achieved what was expected of their exercise capacity. And people who did not had worse long-term outcomes. These, believe me, these were all asymptomatic patients, okay? So HCM, stress echo plays an important role in HCM. Another important thing, especially for imagers, et cetera, and I will show a case of this, systolic anterior motion associated mitral valve, which is very common in HCM, is typically posteriorly directed, like in the top left panel. If you see a jet of MR going anteriorly, doesn't matter if you have outflow tract obstruction or not. That is primarily due to some intrinsic mitral valve pathology. And you need to warn your surgeon if they are going to operate. You need to tell your interventional cardiologist that alcohol septal ablation may not be enough. So something important. This picture is also important to pay attention to. The other thing is, more than a decade ago, we recognized that not all hypertrophic cardiomyopathy patients have hypertrophy. They have dynamic outflow tract obstruction in the absence of hypertrophy due to subvalvular pathology, mitral valve, papillary muscle, what have you. So if you have a symptomatic patient whose echo is suggestive of obstruction, you have to identify where the obstruction is coming from. Designating somebody as not being HCM in the absence of hypertrophy in 2025 is also not appropriate. In our practice, about 80 to 85% patients look like the thick wall on the left, but 15 to 20% patients look like the rest. Okay, so this is important to characterize because there are treatment scenarios. Obviously, phenocopy assessment is important. You do not want to treat an amyloid patient with mavacamten, and you do not want to treat an HCM patient with tafamidis. The last thing you want to do is take an amyloid patient to the operating room. right? So using multimodality imaging, multi-parametric CMR, including SCAR LGE assessment, strain assessment on echo, just routine cine assessment on MRI and echo, all these things would potentially get you to a refined diagnosis. So enough of diagnosis. I think now I'll spend most of my time talking about where we are right now and where we are going. So some fundamental things in management of obstructive HCM. As I said, these patients present with dynamic LV outflow tract obstruction. What does dynamic mean? It changes. It's kind of like my wife's moods. It changes from time to time, right? Dynamic. So you can make things worse by putting them on inappropriate medications. You dehydrate them. You give, if they drink a lot of alcohol, that can dehydrate them. That can put them in atrial fibrillation, rapid tachycardia. All these things can make things worse. Wrong medications can make things worse. So before we think about fancy things, you have to think about basic things. I routinely tell my HCM patients, do not drink alcohol. Treating them for sleep apnea is diagnosing and treating their sleep apnea reduces arrhythmia risk, which helps with their symptoms. Exercise, a lot of, back in the day, people were scared to exercise. Now there's emerging data. Aerobic activity, not a problem. Aerobic activity, not a problem. Coming to the treatment landscape, as all of us know, HCM was first discovered in late 50s and early 60s. Dr. Brownwall wrote the first clinical paper on this. Since then, till about 2018 or so, what was the treatment landscape? Beta blockers, calcium channel blockers, disopyramide. What was the data behind all this? Zero, right? Most of it is observational data and consensus opinions. And no randomized controlled trial data. So we have long recognized the need for medical therapy. We have long recognized the need for medical therapy. Even with the advent of myectomy and alcohol septal ablation, this is the fact, the bottom line below. Less than 2,000 myectomies performed in USA, less than 600 in the 4 large medical centers. Cleveland Clinic is one of the largest centers, if not the largest center. We do about 200 myectomies a year. So at the very least, we need better treatment options, right? Lesser invasive, non-invasive treatment options. Septal reduction therapy is important, but it is more important to be done by the right surgeon. And as I've shown you, this is a cartoon of what we offer. If you have a thick wall heart, you do a myectomy. What happens when you do not have a thick wall and your driver of the problem is a papillary muscle or mitral valve? You've got to fix that. For that, you have to recognize it first. And almost always recognize that alcohol septal ablation in this scenario, in the atypical scenario, is not going to work. So you need an experienced team to handle these cases. The guidelines say what? Yes, go to an experienced center for a myectomy or alcohol ablation. There's not enough experienced centers. You come to Cleveland Clinic, 0% mortality. But overall mortality, 16% in less experienced center. But what is the fundamental reality? The curve on the right says there's an inverse association. The more your experience, the less your mortality. Yet, even in USA, 70% patients undergo SRT procedures in low volume centers, probably driven by the institutional desire to keep their patients within the system. You all know everything about that, right? So this is another sad reality. We can have the best surgeon, but if there is no patient coming to see that person, nothing's going to happen. So what do we need? We need non-invasive medical therapies. which is where the cardiac myosin inhibitors have emerged in the last few years. These are precision drugs that work on the actin-myosin cross bridges within the sarcomere. So they're boutique drugs developed specifically for this disease. HCM heart is in a state of significant hypercontractility, and it is a poor utilizer of energy in that state. What these drugs do is they work on the actin-myosin cross bridges and reduce the energy inefficiency, reduce the severe hypercontractility, making them just contractile enough for improvement. Mavacamten is the first in class that is currently approved in multiple countries in the world and soon coming to a pharmacy near you, and aficamten is currently in development. So let's look at the timeline. 60 years, no data, or consensus opinions, or observational data. Now we have 6 randomized controlled trials, placebo, phase 3 randomized controlled trials. Okay? 4 in mavacamten, 2 in aficamten. And this started in 2018, 2019, 6-7 years. Right? We have come a long way in a very short time. Before I talk about what some of the data is, I'll start by showing you a case. This is a 61-year-old patient of mine, but was being followed up at the executive high. He was like next in command to the CEO of a petroleum company. Goes to the executive physical with all the symptoms, all the hypertension, coronary calcium score, everything, okay? About early last year, we had started a program where we sent every ECG for an analysis by artificial intelligence to diagnose HCM. The new program we started. That flagged this patient. If you look at the ECG, this patient does not have LVH. Everything that we learn in textbook, even the electrophysiologist here would say, this is a normal look, this does not look like HCM. He was flagged, referred to me for evaluation, which confirmed that he has basal septal hypertrophy with SAM and severe outflow tract obstruction. So what did I do? We started him on mavacamten. In 12 weeks, he is doing great, asymptomatic. So the reason I like to show this case is it takes into account 2 novel ideas moving into the future. Using AI to diagnose patients, and once you diagnose, treating them with precision medicine to relieve their symptoms. We got to do good by the patients. Make the right diagnosis, then treat them appropriately. Second case, this is a 78-year-old female. Why? Yeah. 78-year-old female with history of dyspnea and exertion. I saw her 6 months ago, 6 months prior to initial presentation. She was diagnosed with asthma all her life and treated on all kinds of medications. Okay? Comes to me, we make the diagnosis of hypertrophic obstructive cardiomyopathy. She says, I do not want surgery. Mavacamten was still not available. I'll wait. Do the right things first. So I stopped the losartan first because that can aggravate outflow tract obstruction. Because of potential concerns of drug-drug interaction between omeprazole and mavacamten, we switched her. So I was getting ready for when the drug was launched. And once the drug was launched, we started her on the drug. And within 12 weeks, she's non-obstructive, doing great. The first follow-up visit, she told me, thank you for curing my asthma. Patients don't know, right? They were feeling better. She still is doing great. So where does the data come from? The Explorer study was the first study looking at placebo versus mavacamten for 30 weeks, looking at improvement in physical activity and improvement in their NYHA class. In addition to that, looked at gradients and Kansas City score, biomarkers, diastolic function, all the things. 73% patients were in NYHA class 3. You don't need to memorize all the graphs, but fundamentally, compared to placebo, no matter what endpoint you looked at, mavacamten p-value was highly statistically significant. So again, first time a drug compared to placebo, similar to what we are used to seeing in statins and other therapies, right? Additionally, it also showed that it does work at a sarcomeric level. Mass regressed, LA volume index regressed, diastolic function improved, MR improved, SAM improved, in addition to patients feeling better within 30 weeks, right? One can argue, it's only for a short term. In the long term, everything comes back. Not true. 180-week long-term follow-up. Some patients are now on these therapies for more than 5 years. They continue to do well. Majority of them asymptomatic. Gradients obliterated. But FDA wanted a little more. What their thought was, okay, you can treat simple patients, but ultimately a lot of these patients undergo cardiac surgery or alcohol ablation. What can this drug do? So let's look at this patient, 62-year-old patient of mine. Again, she was referred for surgical myectomy. Known obstructive HCM, she was on appropriate therapy. Resting gradient 19, Valsalva 63. We put her on a treadmill. The gradient jumped up to 130. This was around the time when mavacamten was just approved. So she goes, I'm willing to try this. So I think she was my third patient we put her on. That was in 2022. She became non-obstructive and has remained non-obstructive, avoided surgery since then. Okay? Case 4, another one of my patients, 71-year-old male, diagnosed 3 years ago with obstructive HCM. So that means for 68 years, he was walking around without an appropriate diagnosis. About a year prior to presentation, somebody did an alcohol septal ablation in him. Did not work. Very symptomatic. If you look at there's alcohol. Alcohol did go somewhere, but not the right place. Severe gradient, 84 at rest, 118 with Valsalva. You can even see the arrow where there's a thick, full thickness scar in the LV. So, the worst of both worlds. He's got a scar to prove, but no symptom improvement, okay? Clearly, he was, again, referred for surgical myectomy, but the problem with this patient is what? Alcohol septal ablation, high likelihood of right bundle branch block. Surgery, almost universally, you're going to get a left bundle branch block, which means you get a free pacemaker. Not a free, but you definitely get a pacemaker. So we, again, put this patient on mavacamten. No, actually, this patient, we enrolled him in the Valor trial, which we will talk about. At 32 weeks, totally normal. Okay? But more importantly, that was his ECG before, LVH with strain pattern. After 32 weeks, normal ECG. First I thought this was a mistake. This was somebody else's patient, somebody else's ECG. It was not. Patient was completely relieved of LVOT obstruction. He was unable to climb a flight of stairs. Here he's planting his garden. One more case, 23-year-old male, known HCM for 10 years. Past surgery. He had a myectomy done 8 years prior, another myectomy done 4 years prior, and another by a very experienced surgeon. Look at the echo. This person, when I looked at his echo, this does not look like somebody who had 2 myectomies. Terrible job. His apex is blown out. He has an apical aneurysm and severe gradient. How are you going to handle this patient? Do you send him for a third open heart surgery, or do you discuss medical therapy? That's a question for everybody, right? So that brings us to the VALOR study. This was designed, and full disclosure, I ran this trial, so I was a principal investigator. So highly symptomatic patients, all referred for septal reduction therapy, randomized to placebo for 16 weeks or mavacamten. After 16 weeks, everybody crossed over to mavacamten. What was the principal endpoint? Can we reduce the need for surgery or alcohol ablation? At baseline, 100% patients in blue, they were surgical candidates or alcohol candidates. At 16 weeks, 82% no longer met criteria, which was sustained over 56 weeks, where 9% continued to meet criteria. Look at the red bars, 100% placebo patients, 77% placebo patients at week 16, but once you transition them to mavacamten, they started doing really well. They start behaving like the other group. Additionally, similar to the other trial, at 32 weeks, 56 weeks, and 128 weeks, we are able to show reduction in mass, LA volume, strain, left atrial strain, left ventricular strain, diastolic function. So sustained improvement in addition to the gradients and symptoms. At 128 weeks, only 7 out of the more than 100 patients have undergone SRT. So, and all of them are now taking commercial mavacamten and doing well. So we were able to reduce the amount of needed procedures. Pooled safety data from both the trials show a less than 5% reduction in ejection fraction that required an interruption of therapy. These are cardiac myosin inhibitors, so they are going to inhibit the cardiac myosin. So we got to make sure they don't overdo it. Quickly, the guidelines have recognized, and in the American guidelines, they get class 1 indication if you have failed beta blocker therapy. Same way ESC, symptomatic patients, try first-line therapy, and then move to mavacamten. And if that doesn't work, septal reduction therapy. Now, one word. In our practice, we don't use disopyramide as much, okay? I reserve disopyramide for my mother-in-law or patients that I don't like, okay? Other than that, we don't use that often. So mavacamten was launched in 2022 in the United States. What's an ideal patient? Symptomatic patient with obstruction and preserved ejection fraction on one background medical therapy, okay? With a diagnosis of HCM based on these criteria. So it is important, now you hopefully realize how important echo has become in this context. FDA approved this under what we call the REMS program, Risk Evaluation Mitigation Strategy, meaning they wanted to know every patient, every echo that was done had to be recorded and uploaded into a database, a federally mandated database. Initial visit 4, 8, 12, so once a month, and then every 3 months. Because of favorable data last year, earlier this year, we moved to every 6 monthly echo. But in India, I think when it is going to be launched, it will still follow the old regulatory requirements. But what this has done is it initially was a daunting task to set up these databases, but it has given us an opportunity because it has created the world's largest HCM echocardiography database. So this is a paper I published last year on more than 6,000. Now we have 20,000+ patients on this. 6,000 patients across USA. Every patient was included here. No exclusions. The drug-drug interaction business occurred in 0.5% patients, so not that big of a deal. We quickly adapted. The incidence of temporary interruption due to low ejection fraction, less than 5%. The white column of 0.9% is there were 29,000 forms submitted, of which less than 1% had an ejection fraction of less than 50%. Heart failure hospitalization was 0.3 and 1.3%. So fairly safe. Dosage. We were able to achieve maximum efficacy at the lowest 2 doses. This is important because the more you do, the higher the likelihood of you running into trouble with ejection fraction. So this is very efficacious at the lowest dose. And the gradients, they behave similar to what we were able to see in the clinical trials. Okay? Now, earlier this month, we presented our data from the Cleveland Clinic. Now we have close to 300 patients on this. So this was last September cutoff of 244 patients who got at least 3 months of mavacamten. 171 got more than a year of mavacamten. The interruption occurred in 3.2% patients. Only one of this patient has needed SRT just yet. Only one. Okay? Thank God my surgeons like me for other reasons, but it is what it is. But similar to trials, gradients, LA strain, LV strain, mass, diastolic dysfunction, everything trended in the right direction. Okay? So this works even in the real world. In fact, I would say the results are better in the real world because we are a little bit more careful how we dose titrate. Now, couple of things before I close out. I titled this, "A Campton a Day does not always keep a surgeon away." This is a 63-year-old patient, known obstructive HCM. Somebody did an alcohol septal ablation a year ago. Didn't work. So they started her on mavacamten 4 or 5 months ago. Still remains symptomatic and referred to Cleveland Clinic for further management, labeled as mavacamten failure. Just look at the TE in the center. This is an anteriorly directed jet of MR with flail posterior leaflet. Of course, in addition to that, patient also has obstructive HCM physiology. This patient, there's a reason why they did not completely improve. They have severe MR, that is anteriorly directed primary MR. So we stopped the mavacamten, fixed the mitral valve, and did a myectomy, and the patient is doing well. So ultimately, you still need to make the right diagnosis. Another patient, 72-year-old, diagnosed with obstructive HCM. She had alcohol septal ablation, and she got a free gift of a permanent pacemaker at that time. Still remained symptomatic, started on mavacamten, again referred for failed mavacamten. Okay? When I saw her, the 2 things that caught my attention were the bottom 2 things. Bottom left, moderate jet of AR and a fixed LVOT Doppler obstruction Doppler pattern. So then we did an MRI which confirmed that she had subaortic membrane. Again, not obstructive HCM. So membrane resection, a little bit of myectomy, life goes on. So when you call something, this is a failure, is it a failure of the drug or is it a failure of you being able to diagnose the right problem? So as I end, I think I've hopefully made a case that the future is bright here. It is not a competition between your scalpel, your catheter, and my pill. It is how we can provide the best quality of life for your patient. Thank you so much.